Um, if you don't mind, let me just, I know you guys know each other very well. You knew each other before you knew me, but I met Dr. Purcell as a part of the Free Market Medical Association that we pitched in together and tried to get going here in the Carolinas. And I think we did a good job advancing, that cause. And then I met Dr. I at that same meeting, and I'm going to rely on you, Dr. I, to help me keep pushing forward with the Free Market Medical Association in the Carolinas. So for anyone who hears this recording and wonders what that is, I hope that the next meeting that we have will be even bigger than the first two. So, I met Dr. I again many times, and you have advised and mentored me and given me resources that have helped me continue to preach this gospel about how direct primary care is indeed, and I've seen this play out, it is the first and best cost containment strategy that a self-funded health plan can employ. It's not only the easiest, but it's the most effective cost containment strategy, and people don't really realize how much money they're burning in primary care when a carrier is involved in paying that in a third-party way. So I want to thank the both of you for what you're doing and the way you led your industry and blazed a new trail. And part of what I want to talk about today is how differently direct primary care is reacting to the COVID-19 pandemic, where we're seeing a very different story playing out in traditional primary care practices. So this is being recorded, and I'm going to use it to continue to advance the cause of direct primary care. So use this time to go ahead and tell folks about your book and why you wrote it and what it's about.
Can you hear us, Jerome?
Mm-hmm.
Yeah, I can hear you. Can you hear me?
Hi, Dr. I.
Yep.
Hey, how are you?
I'm good. I hope you are too. I like your t-shirt.
Oh, thanks. Casual Friday.
Yeah, that is awesome.
So Dr. Purcell has written a book, and I'm so excited to buy a whole stack of them and hand them out to friends and colleagues. So tell us about it, Dr. Purcell.
Well, it's hopefully a helpful book on how to use DPC with employers basically from a direct primary care physician's viewpoint. And so after chatting with lots of DPC docs like Jerome and others who've been working with employers for a long time, and several benefits advisors who try to help DPC physicians, and working with some small employers, getting their take on how they feel about working with DPC. Mm-hmm. One of the main questions we get a lot from physicians who are transitioning into DPC, or they're starting up their DPC and maybe they're a year in and they're starting to get small employers or larger employers asking them for services, is they want information on how to do that, how to work with employers, how to find employers, how to work with benefits advisors, how to structure contracts, what are the landmines and pitfalls they need to watch out for, so that the Alliance gets those kind of questions all the time, lots of questions like that at different conferences. So we have some information on the DPC Alliance, our university page, which is lots of articles about learning how to work with employers, where to go to get some contract help, what are the rules and regulations for your state. But we don't have a handy, guide, A to Z guide to try to help people with tips on how to do it. So over the past 6 or 8 months, I've been putting together this 9-chapter book basically that talks about, how to find employers in your area, what are some good contact ways to get in touch with those employers, how to find benefits advisors that hopefully understand DPC, and then some questions to ask those advisors to sort of vet them to see, do they really understand DPC, or are they just coming to try to get a handout?
Right. That's a very important key, I will say.
And then
coming from my standpoint.
yeah, so all those different things, and there's a lot of part of the book. Half of the book is our story, basically about how we did the large employer in our community, the county employer, the pitfalls and landmines, the things that we ran up, so people can be prepared for those things and ask questions ahead of time. Just things to think about, so you don't end up right back into a fee-for-service type business if you're not careful. If you get a large employer like a 1,000 employee municipality, if you're not careful, you'll be doing prior authorizations, you'll be doing medical management, you'll be doing the same kind of things you left primary care fee-for-service doing. So you need to think about that up front. And that's why a lot of DPC folks, they just like the small employers. We'll stick with the 20 or 30s, and because we know that they're not doing a lot of insurance, and so they won't interrupt us. But hopefully it'll be a helpful book. I've just got back to proof, and so hopefully it'll be available in the next month or so. I was hoping to have it for our DPC Summit conference in July, but it looks like probably 99% chance that conference is going to go virtual and not be held live. So hopefully we'll be able to share it and get some good feedback. And full disclosure that the section in there that Christy Gupton did help me with some benefits quotes. There's large sections in there with her comments. There's some information in there that quoting a lot of stuff about Health Rosetta and how to connect with those folks. But a lot of other organizations too, Free Market Medical Association, a lot of other places that people can connect to try to learn how to do employer-based DPC type stuff.
That is awesome. I got a text just now from Dr. Matthew Kramer in Forest City. And so I hope the recording is not showing me sending him another invite. I hope that's blind from the screen, my multitasking here, but I would love for him to join us. So I hope he gets that invite again. He must have deleted it the first time, but remind us what the title of the book is and when you expect it to be available to people.
It's called Magic, Pixie Dust, and Miracles. A guide to direct primary care and employers. So hopefully I got to get it back to the printer, and apparently they're not doing a whole lot of printing right now. So they're eager to get my money. So
yeah.
So I suspect I'll probably have it in the next month or so, and try to get it on Amazon, and I'll probably be sending several copies to different people and let them read it and share it. And hopefully you and Carl Schuessler, and because Dave Chase wrote the foreword for the book, so I'm going to give him a few copies to share around. And so hopefully it'll be helpful to, it's primarily, like I said, it's primarily for DPC physicians. It's from our aspect, how we're coming to the situation. However, there's a ton of information in there for advisors, a ton of information in there for employers to understand where DPC docs are coming from. and the sacrifices we've made to do what we're doing,
Mm-hmm.
and that we don't want to go back to the old way.
Right.
And so at least they have an understanding that, where we're coming from as far as data and EMRs that we use, and the services that we can provide, and all the benefits, but also what limitations, that we're not going to spend 45 minutes on the phone trying to get all these things approved, and we want to take care of patients.
Right.
So hopefully it'd be helpful. And
I can relate to having to constantly defend my new position, right? No, I'm really don't want to quote Blue Cross for you because as an advisor, I can't defend, their position in the marketplace and the prices that they charge and the way they run up healthcare costs. And, I can't go back to the old way, just like you said, Dr. Purcell. That method of paying for healthcare is foreign to me now. So when I constantly have to explain to folks too why it is I do things this way now, and I don't want to go back to the past.
I'd like to hear what Jerome has to say about the how his employers are faring with the coronavirus and how that's panning out, and because we've heard some
Yeah.
our employers have been.
Yeah, Doctor. It's a very different setup. So definitely, Doctor. I settle in on Dr. Purcell's question first, but I think this discussion is going to be very interesting. So hopefully there are doctors in traditional primary care that end up seeing this recording and they're wondering, hey, why didn't I gravitate towards this model a long time ago? So
Sure.
Thanks for joining us.
Yeah, I'm sure Shane and like myself has probably gotten a lot of calls in the new year, even before the COVID downturn, regarding jumping ship out of the big corporate medicine and getting a DPC. I probably get at least a call every week from a physician in the Carolinas. And Shane, I'm also looking forward to your book. And to answer your question, the coronavirus situation has really given us the opportunity to kind of really look inwardly at our value that we present to our members. It's been a great opportunity for us just to realize that, this is great to be out fee for service, because we're taking care of our members without having to worry about how we get paid, because we're already getting paid, and those members see our value. Other than coronavirus, life still goes on, and there's other medical problems we still need to address, and we can address that virtually, through text, through conversations with some of our staff. Our staff has become family with many of our patients, so they'll call and want to speak to Molly, for example, and say, "Hey, Molly," sometimes they rather speak to Molly and send a message to Dr. Aya, because they think I'm busy or just don't want to interrupt my day, and they like Molly, so she's part of their healthcare family, and so they send a message to her, they relay to me, and I get back to them, or we set up a virtual meeting to take care of their needs. It's interesting that we kind of ramped up the virtual office visits, and a lot of patients have given me tours of their homes, which is interesting.
I know home visits are back in fashion. Isn't that great? It's like Marcus Welby all over again.
Yes. Virtual home visits.
Well, that's why I'm so disappointed that Dr. Kramer can't get in. I'm going to keep trying, but he in Forest City, North Carolina, was moonlighting at some ERs while he got his practice going, but really started building his patient base on actual physical home visits. And
Wow.
yeah, and it's so cool. He has an RV, so he kind of travel around, and his kids are homeschooled, and so he could go wherever he needed to go and see patients wherever they were. I think there's a picture on his Facebook page showing him stitching up some guy at his kitchen table that had cut his hand or something like that. So it's so cool. It's like you guys are the modern day Marcus Welby's, and I've said that so many times. Like DPC is a lot like Marcus Welby with technology.
That's awesome. That's awesome. Yeah. So yeah, we've been doing fine. I had actually a county medical society meeting last night, a Zoom meeting last night, and just to hear some of the specialists and some of the other family docs that are going through some issues with patient flow and how to jump on the telemedicine. They had to sort that all out. So I think as a DPC doc, I think Shane can attest to this, that we were in a better position. We didn't have to change much in order to accommodate our patients' needs.
Yeah, I think that's probably the best story of all. And Dr. Eric Bricker, that has a great video digest that comes into my inbox daily. Yesterday's video was a lot about how normal traditional practices have seen such a dip, and the volume, their patient volume has dipped so badly, and how that has caused furloughs and providers to be laid off, and things that are really upsetting to the whole healthcare space. But the ones that are left are starting to do telemedicine, but at a fraction of the reimbursement rate. And so they, one of the things he predicted was the fact that the carriers are going to have much more of a bargaining position. They're going to have more leverage when the next time it comes to negotiate those contracts, and the providers are going to be, in a position of disadvantage because, they're going to be cash needy. And you guys are just not in that position because your revenue has not been affected by this crisis. Your patients, have already budgeted for that. And that kind of brings in something that another doctor, here comes Dr. Aiken. Let me get him in the room. Another doctor out in Denver, Colorado. I was on the Health Rosetta webinar last Friday, and a Dr. Bender, Dr. Bender from Denver, Colorado. He says, it makes the very valid point that, we don't use our car insurance for tire changes and tire rotations and oil changes, and we really don't need insurance for primary care, although the carriers would have us believe that's what we need. So I think it's one of the factors that I wanted to bring up. It is about what's going to happen going forward because of this pandemic. I know that many primary care practices are going to be in a poor financial position, and I kind of hope that they look at another way of doing business, another way of serving their patients. I know that all practices are a business, but I don't think that that's always first in a doctor's mind. A doctor's what is front of mind in a doctor's situation is the care of the patients. So let me pause here and welcome Dr. Ben Aiken to the room. Hi, Dr. Aiken. Can you hear us?
I can hear you. Sorry of my lapse of timing this morning.
No problem. We're just glad you're here. I kind of went around and explained how I met each of the folks. And if and I know you've met Dr. Purcell and Dr. Ai as well, also through the Free Market Medical Association. But I met Dr. Aiken in Asheville, North Carolina, and I have a couple of employers that I have connected with Dr. Aiken, and he is, and when I said earlier that direct primary care was the first and best cost containment strategy, it is data that I'm getting from one of those two employers that leads me to know that that is absolutely true, because there is a case where Dr. Aiken assessed and evaluated an ACL tear for an employee in one of my groups. And we were able to sort of triage that from a next step standpoint. And instead of that employee going to the hospital to have that surgery done, we were able to redirect it to a freestanding ambulatory surgical center and negotiate a bundled rate of $6,800. And so that employee got their knee taken care of, and the plan didn't pay $32,000 like they would have if that employee had gone to the hospital. So when I say DPC is the best cost containment strategy and the one that should be deployed first, I say it from a position of experience. He must have I could tell his screen stalled and he's dropped out of the room, but anyway, hopefully he'll be able to come back. And I spent time creating a couple of slides with a couple of good questions to kick off conversation with. And of course, since I did it on my son's Mac, now I can't find it. But one of the questions we've already kind of addressed, which, the difference between how you are able to maintain care without seeing a drop in your revenue. And that's a stark contrast between direct primary care and traditional primary care. But let's talk about how the patients are experiencing their memberships with you and how that's different from traditional primary care. And let me just tell you that I attempted to, and this was early in March, so it was before a lot of this, crazy time that we're in got started. But disclosure here, and you guys know this because you all know me, but we don't have direct primary care in my hometown. So I'm stuck in the traditional world like millions of other people. And I lament that fact every day when we have to navigate an inefficient world for primary care. But my 13-year-old son really just needed a refill of a prescription. Lisinopril is the one, a simple drug. It costs pennies, right? And that's really all he needed because he has a high blood pressure, was diagnosed when he was 9 years old. So just a simple medication kind of manages it. But we were changing pediatricians, changing providers, and just trying to get on the schedule for an after-school time slot, right? So this was when school was back in, we were still going to schools. It was early in March. And so I was really just looking for some appointment slot that was after 3 p.m. And trying to just schedule that appointment was going to take 6 or 7 weeks from the date of the phone call that I made. So that is just incredible to me. That there aren't enough appointments on the schedule to just fit in a kid that really just needs a simple evaluation and a prescription written. And so, I think that the way the patient experience is different is something that we ought to talk about, if each of you have a good story about how one of your members, one of your patients was able to just get right in and get right to the fact of the matter and be able to take care of their needs without having to, deal with the current state of traditional primary care. I'd love to hear some good stories.
Hey, Christy. This is Matt Kramer.
Hey, Dr. Kramer, thank you so much for joining us. I'm sorry that the link to the Zoom meeting is difficult to manage, but we're so glad you're at least on the phone with us.
Sure.
So I hope
example,
I'm sorry.
So an example of a patient just being able to jump right in would
Yeah.
be a patient of mine that has severe allergies. He gets injections done by monthly serum injections, and he just moved to North Carolina, had not been established with a allergy specialist here, but I was able to coordinate with his allergist in Montana to mail his serums out to me here. His serums just arrived, and he was getting due for his serums, and his father passed away tragically, and they had to get on the road the next day. I was able to meet him at his house and give him his injections at his house just before he got on the road the next day.
Gosh, I hope your ears were burning a few minutes ago, because I was talking about you and saying that in the early stages of you founding your practice, you brought home visits back into fashion. I think that's awesome. I've often called direct primary care doctors like Marcus Welby with technology, and it really is true. And I even told these folks that there's a picture on your Main Street Family Medicine Facebook page of you stitching up a guy's hand at his kitchen table. So
Yeah,
I
that's
think
right.
that, I think the home visit is coming back into fashion, and that's a good thing.
I really agree. It's not always the easiest on the provider's time schedule. However, direct primary care opens up our schedule in a way that we've never had before. And it gives us an opportunity to truly capitalize on a relationship. And we're willing to maximize that by investing time and energy into the relationship that we've never been able to do before.
Pardon me, I just had to go let the dog out. She was about to get a little more fervent with her barking. So
Yeah.
I just decided to let her get what she needed outside. So how about you, Dr. Aiken? Do you have a good story about a patient that you were able to just lickety-split, take care of what they needed? And if they had been a patient of a traditional primary care practice, where that would have likely not happened?
Yeah, I think it becomes actually kind of, not to a degree, excuse me, old hat. This story kind of repeats itself pretty regularly, I feel like, and we get the feedback of, wow, that just was so easy. A recent story was a patient that really had been out of care for over 5 years, a previous history of some high blood pressure, as well as pre-diabetes, but really had just been out of care, hadn't had any regular care, had done some good work to improve those things and get off of medicines prior to that 5 years ago, but really then kind of unknown. But ultimately presented with what was suspected to be a kidney stone, and ultimately, in the midst of COVID nonetheless. We ultimately were able to have daily check-ins over the first 48 to 72 hours, manage most of that virtually, and then have follow-up in person within a 2-week time frame, all of which basically allowed him to manage that without any expensive imaging and without any additional visits for specialists or other things. And then now, have him very well positioned to start working on those other things after having addressed this acute issue for him. So that one comes to mind.
That's very cool. And yeah, the outcome of having to wait on, an appointment for a number of weeks just to see a provider would have been detrimental to that person.
Mm-hmm.
Dr. Ai, how about you? I'd love to hear one of your stories.
Sure, and just like Ben said, this happens probably almost every day, where even as simple as, hey, I'm a truck driver, I forgot to let you know that I'm out of my medicines. I'm in Minnesota, and I see a Walmart down the street. Do you mind me sending my diabetes and blood pressure meds to that Walmart? Sure, no problem. Or even this week, we had a female, my right calf swelling, have some pain in my leg. Very low index of suspicion that it might be what they call a deep vein thrombosis, a clot in the leg. But she was concerned. She had risk factors. She was on birth control and mildly obese. So, it's one of those things where, you kind of have, I said we have real conversations with patients regarding what they present with. And so she was concerned. And so we sent her to to get an ultrasound, and it was $100 ultrasound just to rule out DVT. And so, all taken care of that day. So it just lifted a huge weight off her shoulders, and she was on her way just to do her thing.
Awesome.
So just little things like that. They happen probably every week, and they might be small things to larger things that kind of help our patients.
Sure. Dr. Purcell.
Well, like these other guys, I could probably tell 10 or 12 stories, but one interesting one was a gentleman who probably in his early 60s was actually admitted to the hospital on March the 12th. I remember the day specifically because he called our office. This was right as COVID-19 is hitting, and we were starting to shut down offices, shut down things. He said, I'm having shortness of breath, cough, and I cannot breathe. I can't catch my breath. And so I'm coming to your office right now. I said, no, you need to go to the emergency room right now. He did not have a lung history. He was a smoker, I'm pretty sure, but no lung history of taking medications, no diabetes, no high blood pressure. Ended up later that day getting intubated and spent like 4 or 5 days in the ICU. They never tested him for COVID-19. He was never tested. He was positive for flu. Anyway, the story is he finally was extubated, got sent home, and so we were able to do video visits and phone visits within 48 hours of him being home. I've chatted with him probably 15 times in the last 3 weeks to make sure he's continuing to improve, that he's doing his symptom spirometry at home, he's ambulating. His blood pressure has been higher, so we're monitoring the blood pressure from home. He's on a couple of new medications that we're monitoring, all basically through virtual visits, which is good for him because he doesn't have to leave his house.
Right.
And he doesn't want to get out a whole lot. So those kind of things are really super critical for a lot of people, where they'll end up right back in the hospital. And we can sort of help manage those. It could have been weeks and weeks before he saw a system-based traditional family practice for follow-up, which could have been dangerous for this guy.
Right.
So that's one sort of complex story that we were able to help. And he is one of our county patients, so was able to get the care he needed and keep from having multiple. That would have been 10 visits to the doctor, multiple claims, multiple copays. So it really kept the cost down for him. And on top of him being in ICU for 6 or 7 days, there's no telling what the cost of that's going to be.
Right.
Um,
Right. So this kind of brings up another avenue I wanted to go down. Based on your knowledge of this disease, which I'm still confused about a lot of it, but what happens to a patient? And one of the other things I'd love to know is if you do have patients that have tested positive, and how you help them through that. And if that's the case, our prayers go out to each one of them, and we are praying for your protection as well, all of you. But just your knowledge of this disease and how it can come back, because I want to talk a little bit about any advice you have for employers as government officials are starting to talk about reopening the country and employees going back to work and that sort of thing. I want to hear any recommendations you have for employers about that. And what I know what we're seeing in other countries is that there can be spikes. Is there a reinfection possibility? Tell me about the immune response to this disease. Can you get it, and then can you get it again? I mean, I'm just all confused about the whole thing.
Well, I can speak on this a little bit.
Thanks, Dr.
You know, the truth is, Christy, you can get reinfected with any infection over again. And so it's all about, one, how well you know, during the infection that you had with any particular infection, how well you built up an antibody response to it. Many times someone gets a vaccination for something, but they still get the infection later on. It's not 100% guaranteed. And so there's a lot of fear regarding this, and we're also seeing that it is making mutations already. So this is very likely going to become a seasonal infection that's very similar to the flu, where we're going to need to try to project out what mutations are going to be the ones in season that year, and trying to anticipate and build up a vaccination for in the future. In the short term, I think the biggest thing to be focusing on is the encouragement of each of our members, our patients, to be maintaining their health at as high of a percent that they can, and maximizing their own immune system as much as possible. But as far as the specifics on, our capability to develop an immune response and protection from this, that's still up in the air. We don't have a whole lot of data on that yet.
Thanks, Dr. Kramer. Anybody else want to weigh in on that, or have recommendations for employers as they start to at least consider bringing employees back in a few weeks? I mean, I'm still thinking this is bringing employees back to work, in my mind, is probably at least still 4 to 6 weeks from now. But as an advisor, I have to start preparing my clients weeks ahead of time for something that needs to happen. So I want to go ahead and get advice now to send back to employers about what are the best practices that we need to consider about bringing employees back and keeping them safe from, spreading this any more than we've already seen. So anybody else jump in too?
I think I'll make a couple comments, Christy. I think it's really a hard thing because this is new, to counsel, with a whole lot of accuracy. And so I think in some ways, just regular check-ins kind of with updates as it evolves is really helpful. It certainly is an opportunity to highlight for employers kind of the importance of the basics. I mean, like hand washing is, an example of that, but it's just incredibly important as it relates to this. And I do think that it's also reasonable to set the expectation that there likely will be some form of kind of second wave once we kind of open back up, right? Just in the sense of it's unlikely we'll have some type of a vaccination, as Dr. Kramer was describing, in advance of, I think, the fall season. And there's just going to, all of this is kind of a hedged, bet in terms of, okay, we'll open now and see how it goes. And so I think that the encouragement there to the employer groups is to kind of make plans that they could sustain through the rest of the year, like until 2021, rather than like something that's seems like they can only sustain for 2 weeks, just in terms of workflows and bringing people in and that type of thing. Those are just high level thoughts. Not I don't know if there's much specific there, but maybe that's helpful.
That is helpful. I mean, it's eye-opening, Dr. Aiken, because as people are so eager to get back to work, some people are, they're in a very bad place. They're without their income and waiting on the government to sustain them financially. I know that not everyone, but many people are just very eager. They're antsy almost to get back to their lives prior to, say, the middle of March. And that kind of caution, that advice to at least try to restructure your business, not just for the next 4 to 6 weeks, but for the rest of the year, that's very eye-opening. And thank you for mentioning that, because I think we need to be realistic in our recommendations, and because ultimately, if employers are going to bring employees back, nobody wants this to backfire, right? So that's just really important. Dr. Ai or Purcell, do you guys have anything you want to add?
I always reiterate what Ben had said. Basic hand washing, stay home if you're sick. I actually was invited to talk to an employer early on, a cabinet maker in Simpsonville, to their employees, and at the time they were recommending no mask, and later on, of course, they recommended mask, and they've had some issues with some illnesses, coronavirus, presumed coronavirus, and they would call to ask what they should do. And of course, it's stay home until you know the test negative or positive, or at least stay home for 14 days. And so there are a lot of unanswered questions. There's still a lot of questions regarding what we should do. So there's some guidance from the CDC. I don't know by memory, but there are some guidance from the CDC regarding as far as what to do from employers, and we're waiting for guidance. But the basics are the basics, and that's what everybody should do, whether you're home or whether you're at work. And if you're sick, stay home.
Mm-hmm.
Yeah, I think I would join in and say we're in uncharted territory here.
Right.
I mean, this is sort of something we've never dealt with. We don't know if there's going to be a second wave. Most likely, we don't know. There's no randomized, double-blinded studies to say, okay, here's what employers really need to do.
Right.
So we're just sort of guessing, looking at what other countries have done in the past, and to try to make that fit for our employers. Obviously, we're talking about a lot of different kind of employers.
Right.
You got restaurant workers,
Mm-hmm.
which is going to take a whole different mechanism for them to reduce risk. You got people like assembly line workers like BMW and First Quality, and some of these plants, they're going to have to make some changes, to separate districts on assembly lines. How are they going to separate that out? So there's a lot of different things that need about. And so I think employers should start looking, at the CDC, start asking those questions that are specific to their business. If you're an insurance agency and you have 20 people working there and you're all in cubicles, that's a whole different ball game. And if you've got 300 people standing close to each other in an assembly line.
Yeah.
So
That's
I think we
important.
need to sort of individualize it. You know, the basics are the basics, like everybody said, hand washing, maybe setting up hand sanitizing stations within 10 feet of everybody or something. You know, so wearing mask if you're going to do that to protect people. All the basic stuff we can do, but it's going to have to be individualized for every employer, which is going to be something they're going to have to look inward focused to try to figure that out.
Right.
Yeah,
Um,
Christy,
yeah.
I would like to piggyback on that. I think Dr. Purcell's right on. In fact, I'm right now putting together the operating instructions for the South Carolina National Guard. As what the way they're, as an employer, looking at this is in different phases. So they're considering right now that we're in phase 1, and as far as they're minimizing, unless it's an absolute critical function, anyone coming in physically, and they're trying to maximize the ability of getting work done from home or through through video. But what they've done is they've broken it down into different phases. So as we start coming back to work, I would have your employers think about things in terms of phases. And so in the next phase, some of the specific recommendations I'm giving is that when people are in public areas, that they would be wearing a mask during this next phase. That I recommend putting hand sanitizer at all the entrances so that people are wiping their hands as they walk in and as they walk out, to minimize spread of going in and out of from one building to another. Things such as minimizing employees going into another office. So if you can handle it over the phone and you're working in your office and another employee is working in another office, just simply calling each other and minimizing foot traffic within the facility. If you do have to go to another office, that you stand in the doorway, hand something off, and you just kind of stay in the doorway area and you try to maintain social distancing.
Mm-hmm.
Think about the conference rooms that you're utilizing. If the conference room can't handle, social distancing, you might need to look at changing the location so that, the number of people that you're going to be utilizing can still maintain that 6-foot social distancing. And maybe you're going to have to break up a meeting into 3 smaller meetings or things like that to facilitate that distancing. So some real specifics like that. If you want, I could email you a list of what I've been recommending on that type of
Sure,
thing.
I'd love to see that. And thank goodness teleconferencing software like Zoom and Skype and some of those others are accessible on smartphones, right? So having virtual meetings is probably going to continue for a lot longer than anyone realizes.
Yeah.
I would say too, another issue that employers should start trying to figure out now is a struggle even for us in our medical clinic. Is we're mentioning washing hands and sanitizers and stuff. Even just getting that equipment is going to be difficult for a lot of people.
Sure.
I mean, hand sanitizer is not just falling off of trees right now.
No kidding.
And like mask, if you're going to have a restaurant and you're going to try to offer people coming in without a mask to wear a mask, I mean, just trying to find masks and get them is going to be difficult for a lot of employers. So that's something to begin thinking about. Okay, how can I possibly get hand sanitizer or have a hand sanitizer unit somewhere? Because those are probably going to be difficult to get.
Sure. So I want to kind of bring us to a close and thank you all, not only for what you're doing every day, but I want to tell people where to find you and check out your practice. So tell us about your community and where your practice is, and whatever sort of contact information that you want people to hear on this recording, whether it's a phone number or a Facebook page or whatever. And then we'll just wrap it up in a few minutes. So Dr. Purcell, you go first.
Okay. Yeah, so you can find our practices in Anderson, South Carolina. We actually have 4 physicians that work with us. Our practice was started together with Dr. Amy Cianciolo, so we started that jointly and have evolved into 4 physicians. We're desperately seeking a 5th, and we'll probably need a 6th by next year. So we're continuing to grow as more employers drop in. Our website is directaccess.md, so www.directaccess.md, and you can reach me through email. Would probably be the best at Dr. Shane at directaccess.md, Dr. Shane at directaccess.md. And I'm on Facebook and Twitter and Instagram, or LinkedIn as well. I think it's Doc Shane P is how you find me there. But we can certainly answer questions if you email those, try to help people out.
Thanks, Dr. Purcell. Dr. I, tell us about Palmetto Proactive and where you are in South Carolina.
So we're started in Spartanburg, South Carolina. We have 4 locations. We have Spartanburg, Greenville, Drayton Mills, which is in Spartanburg County, and Columbia. We have 6 docs, 2 are part-time and 2 full-time nurse practitioners. We love our community. Just a little plug for what we're doing during this coronavirus economic downturn. For the tip community, people that work for tips, restaurant owners, waitresses, we're seeing them for free. Any money we make from our tips from our current patients, we're giving back to the restaurants buying gift cards. Just want to let you know that. To reach us, you check out our website. We're also on Facebook. My email is jerome.ayay@palmettoproactive.com. And if you want to text me, it's 864-357-1000, or give me a call. That's it.
Excellent. Thank you. Dr. Aiken, tell us about Lantern Health.
Sure, yeah. Lantern Health is a practice in Asheville, North Carolina. We've been around for over 2 years. We originally were called Avenue Health and part of the local health system, but transitioned to an independent practice and rebranded at the beginning of this year, and now Lantern Health. And our website has ample information. It's lanterndpc.com. My direct email address is ben@lanterndpc.com. Those are the 2 best ways, I think, to gather information and get in touch. I have one partner, Rachel Hines, another doctor in the practice, and though young and new in terms of the age of our practice, we're really excited to be a part of the community and push forward this great model.
Great. Thank you. Dr. Kramer.
Yeah.
Give us the lowdown on Main Street Family Medicine.
Yeah, so Main Street Family Medicine is in Forest City, North Carolina, about halfway between Charlotte and Nashville. Small community, and it's a small startup. The business model is going to be where each practice is run by a single physician, so the clients always know exactly who they're going to see at any given time for an appointment, and plan on branching out into all the local small communities around this area. I do CDC type or commercial driver's license, CDL examinations. I'm also working on becoming able to do examinations for FAA, and like you said, trying to bring back home visits as a way of being able to help people who either like for newborns or others that really shouldn't be exposing themselves to potential pathogens. So really starting out brand new here, and you can get in touch with me at Dr. Kramer at Main Street Medicine FC for ForestCity.com, and that would be the best way to reach out, or at my my website, mainstreetmedicinefc.com.
Well, I just want to say thank you to each of you wonderful doctors, not just for what you're doing today, but what you did years ago to step out and try something different, probably in an environment where that made you very nervous. Because you were certainly early adopters of a model that was very different. And I'm going to steal a quote from Dr. Bender. I think his first name is John. Gosh, I might have gotten that wrong, but he's a DPC doctor in Colorado. I mentioned earlier on this recording. And last week in a webinar, he said something so profound. I went back to the recording and wrote it down word by word. And he said, the opposite of cautiousness isn't always carelessness. Sometimes the opposite of cautiousness is courage. And so I loved that quote. I'm going to steal it. I'll always give him credit for it, but I'm just going to steal it and repeat it for a long time to come, because I do think it takes a lot of courage to branch out and fix something that is wrong. Dave Chase always said that when you see something that is wrong, it's your duty to fix it and make it right. And I think that the four of you really saw that there were areas in care delivery that were just not being done at their optimal state, and you decided to have, muster up the courage to change the way you were going to do it, and I applaud you for it. And I think that I hope the message that has resonated in this recording is that the patients and the communities and the employers that rely on you are better off because you stepped out those years ago and did what you did, and the way that you are able to help them today. So we're all very grateful to you, and I hope and hope for you safety and health and everything good to come to you while we all get through this pandemic. Thank you for your time. And if anyone wants to know about me as well, I'm a benefits advisor and I'm a member of the Health Rosetta. My consulting firm is called Custom Benefits Solutions. And you can find me online at custombenefits.work. That's WORK on the end. So I'll wrap this up and say goodbye and thank you, and enjoy the rest of your day, guys. I appreciate your time.
Thanks, Christy.
Thank you.
Bye,
Thank
bye,
you.
folks. See you later.
Take care. Have a good weekend.
Bye.
Thanks.